Hello and welcome to the class. I am Dr. Anumita Chatterjee. I hope you're all in good health and taking good care of yourself. Today we are back with another class, and today's topic is going to be neonatal apnea. Neonatal apnea is also a very important clinical topic, and both from the PG and clinical postgraduates and clinical perspective. So let's dive into the topic. So coming to the definition. So neonatal apnea or apnea is basically defined as the cessation of airflow for at least 20 seconds, or if it can be less than 20 seconds and if accompanied by bradycardia, that is heart rate of less than 100 beats per minute, or cyanosis. So I'll repeat it again. Apnea is defined as the cessation of airflow for at least 20 seconds, or accompanied by bradycardia, that is heart rate of less than 100 beats per minute, or cyanosis. So if a baby is having a cessation of breaths even for less than 20 seconds, and with that has got a bradycardia or cyanosis, then also that is an apneic episode. Now, normally bradycardia and cyanosis usually present after 20 seconds of apnea, and after 30 to 45 seconds, even if the apnea cycle doesn't break, then pallor and hypotonia also set in, and the infant may be unresponsive to tactile stimulation. So there is bradycardia and apnea in premature babies. Okay? Now coming to the classification. Apnea is classified into three types. That is central apnea, obstructive apnea, and mixed apnea. Of these, the most common type of apnea that we see in our babies is mixed apnea. Also, apnea is much more common in preterm babies as compared to term babies. So, in preterm babies also, mixed apnea is the most common cause of apnea. Okay, so what are these types of apnea? Central apnea is seen in around 40% of the babies. It occurs when the inspiratory efforts itself are absent. Obstructive apnea occurs when the baby is having inspiratory efforts. So the CNS is fine. It is giving the signal for respiratory muscles and everything to inspire. But in spite of that inspiratory efforts, there is some sort of airway obstruction, usually at the pharyngeal level, as a result of which the baby is not able to complete the breathing. As a result of which it is known as obstructive apnea. This is seen only in 10% of cases and is the least common type. And the third type and the most important type is mixed apnea. Mixed apnea occurs when airway obstruction with inspiratory efforts precedes or follows central apnea. So there is central apnea as well, and there is some sort of airway obstruction also present, as a result of which mixed apnea results. So apnea of prematurity. Apnea is much more common in preterm babies. So apneic spells occur frequently in the premature infants, and incidence of apnea increases with the decreasing gestational age. So a baby which is 28 to 30 weeks of gestational age has got a much higher chance of having apneic episodes as compared to a baby who is 34 weeks of gestational age. And the various mechanisms of apnea of prematurity we'll be discussing in the later slides. So this is mainly related to the immaturity of CNS, and the characteristic of apnea of prematurity is that apnea occurs after 1 to 2 days of life, but within the first week of life or within the first 7 days of life. If the apnea has occurred beyond 7 days of life, then we have to look into other reasons. And apnea of prematurity usually ceases by 36 to 37 weeks of postmenstrual age in infants born at 28 weeks gestation or more. Now coming to the secondary causes of apnea. These are temperature instability, like hypothermia, and both hypothermia and hyperthermia can cause apnea. But hypothermia has got much stronger association of causing apnea as compared to hyperthermia. Then neurological causes of apnea are because of birth trauma, because of intraventricular hemorrhage and that is much more common in the preterm, and because of drugs. For example, if the baby has been under certain drugs, or there was usage of drugs during the delivery itself, during the cesarean section or during the delivery, as in terms of general anesthesia, if the mother has gotten general anesthesia also. Then if there are intracranial infections or intraventricular hemorrhage, in case of anatomical malformations itself, as a result of which the central respiratory drive or the inspiratory drive itself is absent, because of seizures, because of birth asphyxia. Both birth asphyxia and intraventricular hemorrhage is much more common in and much commoner incidence in case of preterm as compared to term babies. And if the mother has gotten general anesthetics or magnesium sulfate, or if there has been a placental transfer of narcotics, as I was saying, and if there has been congenital myopathies, as a result of which the respiratory muscles itself are weak, and therefore the baby is not able to breathe, a mechanical obstruction. Next, coming to the pulmonary causes of apnea, this could be because of RDS or congenital pneumonia, or there is some obstructive airway lesion, pneumothorax, pulmonary hemorrhage, hypoxemia, or hypercarbia. Cardiac causes are because of cyanotic CHD, PDA, congestive heart failure of the baby, or increased vagal tone. Because of GIT. Now, yes, while feeding the baby, if it's a premature baby and there is gavage feeding or feeding by nasogastric tube, pushing the nasogastric tube too much, or a rough handling of the nasogastric or orogastric tubes can lead to a sudden increase in the vagal tone, as a result of which also babies can have apnea. Then because of gastroesophageal reflux disease, which is very, very common in case of both preterm and term babies, as a result of the reflux, there can be apnea or sudden abdominal distension, gastric aspiration, and even related to sepsis or necrotizing enterocolitis of babies. It's a secondary cause which can cause apnea. Then metabolic causes, the most common is going to be hypoglycemia. And apart from that, there is going to be, it could be acidosis, hypocalcemia, hypo or hypernatremia. So whenever we are evaluating a baby also in terms of for apnea, we have to keep in mind these metabolic derangements. Then next, it could be because of infections. Now we have to keep in mind that these causes, these secondary causes are more commonly seen in case of term babies. Like term babies will not who have got a certain amount of CNS maturity and proper drive. In those cases, it is because of these secondary causes like infections or metabolic derangements or birth asphyxia, which might rather cause apnea. Whereas apnea of prematurity is a well-established thing in case of preterm babies. And if there is any inborn errors of metabolism. So there is one more term that we are supposed to know, that is periodic breathing. This is a normal variant of breathing, and sometimes can be confused with apnea as well. So in apnea, what we are seeing is that baby is not breathing for 20 seconds or so. So something like that. We have to rule it out from periodic breathing, because periodic breathing is a normal variant. What is periodic breathing? It is the recurrent sequences of pauses in respiration lasting for 5 to 10 seconds and then followed by 10 to 15 seconds of rapid respiration. So suddenly we are seeing that the baby is not breathing, and then like the breathing after that for 10 to 15 seconds is rapid or fast respiration. So that has to be distinguished from an apneic episode. Now coming to the incidence, as we know that lesser is the gestational age, more is the incidence of apnea. So as many as 25% of all the preterm infants who weigh less than 1800 grams at 34 weeks have at least one apneic episode. And essentially all infants less than 28 weeks have apnea. So these are the specific causes of apnea. Apnea primarily is caused by prematurity. Then there could be inhibitory reflexes. or CNS pathologies. So as the central respiratory drive is affected, there's a CNS pathology, the central respiratory drive is affected, or central inspiratory drive is affected, as a result of which the baby has gone into apnea. Metabolic disorders like hypoglycemia, hypocalcemia, or acidosis can cause apnea. Then infections, metabolic disorders, impaired oxygenation. These are three causes of apnea in the term babies. These are the primary causes of apnea in term babies, and impaired oxygenation for both. So now coming to the pathogenesis of apnea, this is quite a multimodal approach. There are lots of steps in various modes of pathogenesis of apnea. So we'll be discussing them. But before going into proper discussion, we have to see about the respiratory drive and the respiration in case of babies. So how is the control of breathing done? So this over here is the cerebrum or the cortex. This is the medulla and pons. The respiratory centers are present in medulla and pons. Okay, so this is the central, this is meant for the central respiratory drive. Okay, all the impulses that come here and have a positive or negative, that is stimulatory or inhibitory effect, will may or may not cause apnea. Okay, so basically in control of breathing, this is medulla. When there is emotional stimuli acting through the limbic system, it can cause both positive as well as negative. Too much of elation, usually not in the babies, but normally too much of elation will cause more respiration, whereas depression or sadness or bad emotional stimuli can cause this negative effect. Then higher brain centers or cerebral cortex, which is the voluntary control over breathing, can have both stimulatory and inhibitory drive on the respiratory center. Next is the stretch receptors in lungs. This will always have a negative effect, because if the stretch receptors keep on giving a positive feedback to the medulla and pons, then and there will be more and more inspiratory drive, more and more respiratory drive, there will be a time when the lungs will just burst. So as a result, these stretch receptors, after reaching the optimum oxygenation or optimum expansion, are going to cause a negative or inhibitory impact on the respiratory center. Receptors for touch, temperature, and pain stimuli are going to cause a stimulatory drive. Now, these two are important. That is central chemoreceptors. Whenever there is increased carbon dioxide, that is hypercarbia and acidosis, that will always cause a stimulatory drive or stimulatory respiratory drive on the respiratory centers. That is why our central chemoreceptors have to be extremely active. Similarly, whenever there is in the peripheral chemoreceptors, these peripheral chemoreceptors are carotid and aortic bodies. Okay, so these chemoreceptors also give a positive drive whenever there is decreased oxygen or hypoxia, increased carbon dioxide or hypercarbia, and increased H+ or acidosis. So basically, both central and peripheral chemoreceptors have got a sensitivity pattern to hypercarbia and acidosis. So whenever increased levels of carbon dioxide or hydrogen ions is noted in the body, these both peripheral and central chemoreceptors are going to cause a stimulatory or a positive feedback to the medulla and pons or the respiratory centers, so that we breathe more, and with that the hypoxia subsides and there is proper oxygenation and balance will be maintained. Okay, so we have to mainly remember this sensitivity to carbon dioxide and H+, that is to hypercarbia and acidosis. So this is the first point under pathogenesis, that is the developmental immaturity of the central respiratory drive. The CNS in preterm babies is immature, proper myelination has not taken place. So apneic spells are more frequently seen in the immature infants. Why? So this mainly correlates with the brainstem neural function. As the brainstem neural function has not developed appropriately till now, as per age till now, because of the prematurity, there is going to be more apneic spells. So and as the age increases, the brainstem conduction time for the auditory evoked response also shortens, and therefore the incidence of apnea decreases. So frequency of apnea will decrease over a period in which brainstem conduction time of the auditory evoked response shortens as gestational age increases. Then another thing is the influence of REM sleep. Now, breathing in infants is strongly influenced by the sleep state, and infants, both term babies also, and moreover premature babies, are maximum time they are in the sleep state itself. So active or REM, rapid eye movement sleep, is marked by irregularity of tidal volume and respiratory frequency. REM sleep predominates in preterm infants, and therefore apneic spells in REM are much more higher as compared to quiet sleep state. As a result of which, this developmental immaturity of CNS, both in terms of increased REM sleep pattern as well as immature brainstem neural function, leads to much more apneic spells in immature infants. Now, now the next thing is, as I was saying, preterm infants will respond to a fall in inspired oxygen, that is hypoxia, with initially a transient hyperventilation followed by hypoventilation. First there is hyperventilation and then they go in for the apnea. Okay, this is different from the as compared to the adults. So hence comes the chemoreceptor response. In preterm infants, when there is hypoxia, first there is a transient hyperventilation, then there is hypoventilation and apnea. And why is it so? Because the infant is less responsive to increased levels of carbon dioxide due to immaturity of the peripheral chemoreceptors. In term babies or in younger children or adults, as soon as there is a hypercarbia and acidosis, we will immediately send the positive feedback to respiratory center, start breathing more, balance the oxygen. But here that is not going to happen. Reflexes. Active reflexes invoked by stimulation of the posterior pharynx, lung inflation, fluid in the larynx, or chest wall distortion can also precipitate apnea in infants. So stimulation of the posterior pharynx, for example, when we are too roughly inserting an NGT in that case, or lung inflation, fluid in the larynx, these can also cause apnea in infants. Now coming to the respiratory pump per se. This respiratory pump comprises of two parts, that is the neonatal diaphragm and the rib cage and chest wall muscles. Of course, the rib cage and chest wall muscles are quite weak, and it's an extremely compliant chest wall. And now coming to neonatal diaphragm. So the neonatal diaphragm in the relaxed state is located higher in the thorax, and therefore there is an increased inspiratory pressure. Neonatal diaphragm is attached to a more pliable or a more compliant chest wall. So therefore there will be distortion and hence decreased tidal volume. The newborn is predisposed to fatigue of respiratory muscles also because there is a reduced number of fatigue resistant fibers in the diaphragm. These fatigue resistant fibers in the diaphragm start increasing after birth. Even in term babies, it is just 10% of the total. Whereas in preterm, it is even more lesser. So the respiratory muscles and these fibers which are meant for the diaphragm to be continuously working and supporting in continuously working are much lesser here. Then there's a pliable chest wall. The rapid increase in respiratory rate, which minimizes the relaxation time for the perfusion of the diaphragm. As we know, they will go into a transient hyperventilation after hypoxia, as a result of which there will be increased respiratory rate. So, and which means further more activity, lesser oxygenation of those muscles, and also lesser perfusion of those muscles of the diaphragm. So there is an increased work of breathing. Okay. So these are the various forces which act for the patency of the upper airway. This is the dilating force of the upper airway muscles and collapsing force from mucosal adhesion pharyngeal compliance. So in a nutshell, the consequences of apnea are the gas exchange is compromised because now there's apnea. So basically the carbon dioxide is building up inside the body, as a result of which there will be increased PaCO2 or hypercarbia and decreased PaO2, that is hypoxemia. And with that, because of this increasing PaCO2 and apnea, there will be extra pulmonary shunting and muscle relaxation. So this was the pathogenesis we have discussed in detail of apnea. So so according to the pathogenesis, we have to do the monitoring and find out the cause of apnea. Okay. So in monitoring, all the who are the infants or who are the babies that we want to monitor? Of course, the preterm infants. So all the preterm infants below 35 weeks of gestation must be monitored for at least the first week of birth, because first week after birth. So that is when the apnea of prematurity is to set in, and first week is generally the most important time for apnea to occur. Monitoring should continue until no significant apneic episode has been detected for at least 5 days. So once if the baby has got an episode of apnea, after that we have to monitor at least for next 5 days continuously whether the baby has got apnea or not. So apart from tests and apart from invasive procedures or so, what are the clinical methods? How when we are on the warmers, on the side of a warmer in which a preterm baby is lying, what do we clinically want to monitor? Okay, so in the NICU, when we are monitoring the baby, we have to keep knowledge about the temperature, because both hypothermia and hyperthermia, color of the baby, that is if the baby is having cyanosis, or even if the baby is having plethora, even that can be a cause of, that is increased over viscous blood can also lead to apnea in the baby. But cyanosis has to be monitored. So accordingly, saturation we have to monitor. Active respiratory efforts, because whether the baby is having apnea or not. And for that, there are we can monitor the baby clinically. Apart from that, in Western countries and so there are apnea monitors as well. Then if there is any evidence of airway obstruction, most commonly in the NICU also, airway obstruction itself can cause apnea. It's a very common cause of apnea. So what happens is, for the airway is the most clear when the baby's head is in the neutral position or in a very mildly extended position. But if there is hyperflexion of the baby, so if this is baby's head and this is neck, and there is hyperflexion of the baby's neck, then in that case, what happens is the airway closure occurs. And similarly, if there is hyperextension of the baby's neck also, there is going to be closure of the baby's airway. Therefore, you will see in NICU when the baby is lying in the warmer, a shoulder roll is kept so that the baby's neck is in the optimum position for good breathing. So moreover, hyperflexion and hyperextension of the neck can cause airway obstruction for the baby. Then, of course, heart rate, because if there is bradycardia associated with the apnea, and SpO2, and of course, bedside CBG, because hypoglycemia is also a very common cause of apnea. So this is the detailed evaluation of an infant with apnea that we want to do. So if the baby is having episodes of first episode of apnea, we can see, but if the baby is, we can still observe the baby and rule out the clinical facts. But if we are seeing that in a day the baby has got around 3 to 4 episodes of apnea, not responding, which is not responding just to tactile stimulation, requires bag and mask ventilation, then in that case we have to do a thorough evaluation, and that comprises of these. So potential cause, infection. If it is due to infection, the baby will also demonstrate some amount of feeding intolerance, lethargy, and temperature instabilities, not willing to suck. So in that case, we have to, so for that, we have to do complete blood count, send the blood cultures, and with this even CRP. Then if there is impaired oxygenation, it will be manifested with desaturation or respiratory distress. In that case, we have to do a chest X-ray, arterial blood gases, and also with that continuous oxygen saturation monitoring. If we are in order to rule out metabolic disorders, the baby might have jitteriness and poor feeding, again with that lethargy and CNS depression. So we have to do the ones that matter, that is glucose, calcium, and electrolytes. In electrolytes, we are more interested about sodium. Okay. So in drugs that can cause CNS depression or hypotonia, therefore we would also like to screen for magnesium. And temperature instability manifested by lethargy, so monitor the temperature of the baby. And if since intracranial pathology is a much more common manifestation of is a much more common cause of apnea in case of premature babies, in order to rule out that, we will go for cranial USG. And so these are so therefore every investigation rules out the potential causes. So the investigations we do are complete blood count with CRP and blood cultures to rule out the pulmonary and cardiac pathologies, chest X-ray, saturation monitoring, and also arterial blood gases. Then the electrolytes, magnesium, and a cranial USG. So once we have sent the investigations, now how do we take care of the infant? First of all, we have to treat that apneic episode. We have to prevent that the baby does not have further episodes of apnea, and also find out the potential cause and hence treat that particular specific cause to prevent apnea. So we have to prevent hyperflexion of the neck and hence nurse the baby in prone position. Set the thermal environment to obtain a central temperature of 36.5 to 37 degrees Celsius. Minimize the duration and rate of pharyngeal suction, because both suction catheters or overzealous suction or OGT insertions can increase vagal tone and therefore cause apnea. Then hence place the orogastric tube carefully, avoid a sudden gastric distension, continuous gastric feeding if apnea occurs with gavage, and have warm air and oxygen to incubate the temperature. Now coming to the specific management. So management of idiopathic apnea, when apneic spells are repeated and prolonged, that is more than 2 to 3 times per hour, or when they require frequent bag and mask ventilation, the treatment has to be initiated. So management is fourfold and a multimodal approach, holistic approach to management. So we have general measures, drugs like methylxanthines, and nasal CPAP and mechanical ventilation. So management of idiopathic apnea, we'll first see the general measures. The diagnosis and treatment of specific causes as per the investigations. We have to try to maintain a saturation of 85 to 95%, and therefore avoid any reflexes that may trigger apnea, like suctioning of the pharynx to be done carefully and oral feeding to be avoided during this time. Then position of extreme flexion or extension of the neck should be avoided to reduce the likelihood of airway obstruction and avoid sudden swings in the environmental temperature. Also, PRBC transfusion has to be considered only if the HCT or hematocrit is less than 25%, and if infant has episodes of apnea and bradycardia that are frequent or severe while methylxanthine levels are therapeutic. So next modality is nasal CPAP. Nasal CPAP, we have to give moderate levels of 4 to 6 centimeters PEEP, reduces the number of mixed and obstructive apneic spells. See, nasal CPAP, we have to always rule out central apnea. In a central apnea, nasal CPAP will have no use. Okay. When we know that it is because of a pulmonary cause or because of some obstructive cause as a result of which the baby is not having inspiratory, what I mean to say is the baby is supposed to have inspiratory efforts. That is, the CNS has to be all right. The CNS has to provide respiratory drive or inspiratory efforts. Because nasal CPAP or CPAP mainly increases the PEEP or the end expiratory pressure. So it just supplements inspiratory efforts that are already present in the baby. But if there is a central cause of apnea and there is no inspiratory effort itself, there is no use of increasing the PEEP and there is no use of CPAP in that case. Okay, so the CNS has to be all right. It has to send the respiratory drive, as a result of which the baby will have inspiratory efforts, and that has to be augmented by nasal CPAP. Okay, so it basically maintains a higher end expiratory volume. It prevents the lungs from collapsing, augments inspiratory efforts that are already present. So CPAP may limit the depth and duration of desaturation that occurs during central apnea spells. HFNC can be used to provide increased end expiratory volume. NIPPV may reduce extubation failure due to apnea following mechanical ventilation. So nasal CPAP effects are that it increases the PaO2 with increased lung volume and PEEP. Its primary action is completely on the lung and the PEEP. So it decreases the work of breathing, decreases the splitting of the upper airways, and therefore elimination of the intercostal inspiratory inhibitory reflex. Now coming to methylxanthines. Now methylxanthines have got various modes of mechanisms by which it's a wonder drug in apnea, and that is used very widespreadly now. It has got multiple mechanisms, these beautiful multiple ways of mechanisms by which it is countering the problem of apnea. Okay, so the mechanisms are, first of all, it has got a competitive effect on adenosine receptors. This is the primary pharmacological mechanism by which methylxanthine acts on apnea. Basically, adenosine receptors or adenosine, this has got a negative inspiratory impact, or it causes inhibition of inspiration or inhibition of breathing. So methylxanthine, what it does is it competitively inhibits adenosine itself, as a result of which it increases the inspiratory drive. Okay. Then it increases the sensitivity of the respiratory center to carbon dioxide, because we know that in premature babies, the sensitivity is much low. They are not, it's not sensitive to the high levels of CO2 and the high levels of H+. So methylxanthines are increasing the sensitivity of respiratory center to carbon dioxide. It also increases the afferent nerve traffic to brainstem. So more and more positive stimulation for our respiratory centers to cause inspiratory drive, increased catecholamine response, and increased central stimulation to have furthermore increase in the inspiratory drive. This was what it does on the center. Now, it improves the skeletal muscle contraction, therefore there is more effective breathing, improves the metabolic homeostasis, improves oxygenation via increased cardiac output and therefore decreased hypoxic episodes. It increases the carbon dioxide sensitivity and decreases hypoxic depression of breathing and decreases periodic breathing as well. So signs of toxicity in infants receiving theophylline that is theophylline. Now what we use is caffeine citrate. in most of the places, most of the NICUs, thoroughly caffeine citrate is the methylxanthine that we use instead of theophylline, because first of all, the dose required for both for caffeine citrate is much lesser as compared to theophylline. It also has got benefits as compared to theophylline. For example, sleeplessness, irritability, tachycardia, these things are not seen, or cardiac arrhythmias are not as much seen with caffeine citrate as compared to theophylline. So these are just for therapeutic, for theory. So failure to gain weight, sleeplessness, irritability, tachycardia, hyperglycemia, vomiting, diuresis or dehydration, jitteriness, hyperreflexia, cardiac arrhythmias, and seizures. So what we do is caffeine citrate is available both IV and oral. When the baby is in the NICU, we are going to give caffeine citrate. So when there is episodes of apnea, what we do is caffeine citrate has a loading dose, and then there is maintenance dose. Okay, so loading dose is around 20 mg per kg, and then followed by that the maintenance dose is 5 mg per day. It's an OD dose, and if suppose the baby is having apnea, even after starting caffeine, then a second loading dose is given, which is 10 mg. The first loading dose was 20 mg, followed by maintenance of 5 mg per kg. Then, if the baby has got apnea in spite of methylxanthine therapy or caffeine therapy, then a 10 mg second loading dose is given, followed by the maintenance dose has to be increased 20% of the previous dose. Okay? So that dose is increased, and the baby is monitored for apneic episodes. This has to be continued around up to 34 weeks. And at 34 weeks, caffeine citrate can be stopped. Also, if the baby has started taking orally, and once the baby is receiving everything orally, there are not antibiotics or IV line is not required, the caffeine citrate can be converted into its oral formulation and given up to 34 weeks. So there are certain discharge considerations, and that is we have to always monitor caffeine. Caffeine citrate has got a long half-life, up to around 100 hours. 24 to 100 hours in the body. So what happens is sometimes even after suddenly stopping caffeine, the baby can have a relapse or can have an apnea again. As a result of which, when we are planning discharge, around 5 to 7 days prior to the discharge of the baby, we have to see that 7 days prior to discharge, in those 7 days, the baby has not had any episodes of apnea, and the baby has not been on any caffeine also. So we are going to stop the caffeine 7 days prior to the discharge of the baby and see that in these 7 days, the baby does not have apnea. So if that criteria is met, and other criterions like weight gain per day and baby completely feeding well, no lethargy, nothing, these things are met, then we can discharge the baby. So this was neonatal apnea in a nutshell. With the pathogenesis and treatment. In treatment, what we do is methylxanthines, and of course with that the baby might need nasal CPAP, and if it does not subside with nasal CPAP and the baby is not maintaining saturation even with nasal CPAP, or on CPAP also the baby is having episodes of apnea, in such a case mechanical ventilation might be required. And mechanical ventilation is also given when so mechanical ventilation can be given in the babies who have got even intraventricular hemorrhage. So in that case, if a baby has got intraventricular hemorrhage, in that case nasal CPAP is not going to do much boom, and such babies will have recurrent episodes of apnea and hence might do better on mechanical ventilation. So this is it. General measures which we have to follow day in and day out in order to prevent apnea. With that, methylxanthines up to around 34 to 35 weeks of gestation have to be given. And sometimes with that investigative panel, if required, nasal CPAP, and if does not agree with nasal CPAP, then in that case, mechanical ventilation might be required. So that is all for apnea. Meet you in the next class. I hope you take good care of your health. Thank you.